Welcome to the deep dive. Today we're doing something a bit different, looking at the human body through a really interesting lens, a nursing school exam blueprint.
Hmm. Yeah. It sounds maybe dry, but it's actually a fantastic way to connect the dots.
Exactly. The idea is to see how all these seemingly separate topics, from cells to genetics to stress, how they all link up and give us those aha moments.
Right, because this blueprint covers such a huge range, doesn't it? Cellular stuff, genetics, nutrition, pain, fluids, even skin, eye, and ear conditions.
It really does. So instead of just focusing on one disease, we're going to trace these underlying principles, see how they show up everywhere. It's kind of like a shortcut to understanding some really complex health concepts.
Okay, so if we want to see these connections, where's the best place to start? Probably at the smallest level, right?
Yeah, let's start right there at the foundation, the cell. And this blueprint kicks off with something fundamental, the sodium-potassium pump.
Ah, yes. Sounds basic, maybe, but it's absolutely critical, like a tiny, constantly working engine in every single cell.
So what's its main job? It's about balance, isn't it?
Precisely. It works tirelessly to keep high potassium levels inside the cell and high sodium levels outside. Think of it like a cellular gatekeeper maintaining the right environment.
And it needs fuel for that.
Definitely. It runs on ATP energy. It's an active process, constantly pumping ions against their natural concentration gradients.
Okay, so what happens if this pump fails? The blueprint mentions things like lack of blood flow, toxins, mitochondrial problems.
Right. If the pump doesn't get enough energy or it's damaged, things go wrong fast. Sodium starts to accumulate inside the cell.
But they can't get pumped out.
Exactly. And where sodium goes, water follows. So the cell starts to swell up.
Ah, so sodium swelling, that's one of the mnemonics here.
That's the one. And this swelling isn't just about size. That extra sodium also disrupts the cell's electrical activity. That's critical for nerve and muscle function.
Which can lead to things like weakness or even seizures.
Yes, or heart rhythm disturbances. And then there's the potassium side. The mnemonic is knows X at K plus is low.
Meaning, if the pump knows KNOWS potassium is low inside.
Kind of a memory trick. Yeah. If the pump fails, potassium can't get pumped back in. So intracellular potassium levels drop.
And that also messes with electrical signals.
Absolutely. It contributes to muscle weakness, those cardiac arrhythmias we mentioned, even paralysis in severe cases.
And there's the third part. Power equals cell death. Sounds ominous. What's the calcium connection?
Well, the pump failure indirectly affects calcium levels too. Calcium can start to build up inside the cell when things go wrong.
And too much calcium is bad news.
Very bad. It triggers a cascade of destructive processes, activating harmful enzymes, damaging mitochondria, ultimately leading to cell death. We see this in oxygen deprivation, for instance.
Wow, okay, so that little pump is doing a lot. Now, moving from pumps to cleanup crews, lysosomes and Tay-Sachs disease.
Right. Lysosomes are the cell's recycling centers. They're filled with enzymes that break down waste products, debris, old cell parts.
So in Tay-Sachs, there's a problem with one of these enzymes.
Exactly. There's a genetic defect, a mutation, that results in a deficiency of a specific lysosomal enzyme called hexasaminidase A.
And without that enzyme.
A particular fatty substance, a ganglioside, can't be broken down. It just accumulates, especially in nerve cells, the neurons.
Like stuffing too much garbage into a bin.
A good analogy. This buildup progressively damages the neurons in the brain and spinal cord. That's why Tay-Sachs has such devastating neurological consequences, particularly in infants.
Okay. Next up, ribosomes, transcription, translation, the protein factories. Why is this process so central to understanding disease?
Well, proteins do almost everything in the cell. Ribosomes build those proteins based on instructions from our DNA.
So transcription is copying the DNA recipe.
Into messenger RNA or mRNA.
Yeah.
That mRNA then goes out to the ribosome.
And translation is the ribosome reading that recipe and actually building the protein.
Precisely. Assembling the amino acids in the correct sequence.
So errors anywhere in that chain can cause problems.
Big problems. A mistake during transcription copying the DNA can lead to a faulty protein. This is relevant in things like cancer, where cell growth instructions go wrong. Errors during translation, while building the protein, can also result in proteins that don't fold correctly or don't function. This is linked to lots of genetic disorders, even neurodegenerative diseases like Alzheimer's.
Got it. And the last cellular component mentioned here, mitochondria, the powerhouses.
Yep, responsible for generating most of the cell's ATP, its energy currency, mostly through aerobic metabolism, which needs oxygen.
But there's anaerobic, too.
Right, that's the backup system when oxygen is low. It happens out in the cytoplasm, much less efficient, produces lactic acid as a byproduct.
So if the mitochondria aren't working properly, energy crisis.
Pretty much. Mitochondrial dysfunction hits high-energy tissues, hardest muscles, nerves, think fatigue, weakness. It can affect almost any organ system.
Okay, so that covers the basics of a healthy, functioning cell. Now, let's shift to what happens when cells face stress or injury. The blueprint talks about cellular adaptations, atrophy first getting smaller.
Yeah, the classic example is muscle atrophy when you have a limb in a cast. The cells aren't being used, so they shrink. It's reversible with use, usually.
Makes sense. Then hypertrophy getting bigger, like bodybuilders' muscles.
That's one example, yeah. That's physiological hypertrophy, a normal response to increased workload. But there's also pathological hypertrophy.
Like the heart muscle thickening with high blood pressure.
Exactly. The heart works harder, its cells enlarge to compensate. But eventually that thickened muscle can become stiff and inefficient, leading to heart problems. So treatment aims to reduce that workload, like lowering blood pressure.
Okay. Hyperplasia is an accident increase in the number of cells. The examples are an enlarged prostate and thickened uterine lining.
Right. Often driven by hormones or chronic irritation. In benign prostatic hypoplasia, or BPH, more prostate cells grow, squeezing the urethra. Hormones can also cause the uterine lining cells to multiply, leading to heavy bleeding.
Metaplasia, one cell type changing into another. The smoker's lung example.
Yeah, that's a classic one. The normal ciliated cells lining the airways, the ones that sweep mucus, get replaced by tougher squamous cells because of the chronic irritation from smoke.
But those new cells don't sweep as well.
No, they're more resistant to smoke, but less functional in other ways. The good news is this change can sometimes reverse if the irritation stops, like if someone quits smoking.
Then dysplasia, abnormal cell growth, kind of disorganized. Precancerous, it says. Colon polyps.
Right. Dysplasia is where cells start looking weird, abnormal shape, size, arrangement. They're not cancer yet, but they're heading down that path. Finding and removing dysplastic polyps during a colonoscopy is key for cancer prevention.
And finally, neoplasia. Uncontrolled new growth, benign or malignant.
Yeah, this is the hallmark of tumors. Neoplasia means new growth that's escaped normal controls. Benign neoplasms, like a fatty lipoma, usually stay put and don't invade.
But malignant ones.
Malignant neoplasms are cancer. They
Yeah.
can invade surrounding tissues and metastasize, spreading to other parts of the body. Much more dangerous, obviously, requiring treatments like surgery, chemo, radiation.
Okay, that covers adaptations. The blueprint then really highlights endothelial injury. Why is the endothelium so important?
The endothelium is that super thin, single layer of cells lining all our blood vessels. It's incredibly active, regulating blood flow, preventing clots. It's vital for cardiovascular health.
And damage to it is a big step towards atherosclerosis.
Absolutely. Endothelial injury is a key initiating event in atherosclerosis, the buildup of fatty plaques in arteries, which then leads to thrombosis, blood clots, heart attacks, strokes.
So, what injures this delicate lining? The blueprint lists 4 main culprits. First, hypertension.
High blood pressure. Yeah, think of it like shear force damaging the vessel walls, causing tiny injuries, inflammation, setting the stage for plaque. And it's often silent, which is why regular checks are crucial. Treatment involves lifestyle changes, meds like ACE inhibitors or beta blockers.
Second, hyperglycemia, high blood sugar.
Right, common in diabetes. Excess glucose is chemically reactive. It damages endothelial cell proteins and lipids, causes oxidative stress, inflammation, increases risk for atherosclerosis, clots, nerve damage. Treatment is all about blood sugar control.
Third, free radicals. From smoking, pollution.
These are unstable molecules that damage DNA and proteins in endothelial cells, promote inflammation, and can even make existing plaques unstable and likely to rupture. Antioxidants and reducing exposure are key.
And finally, hyperlipidemia, high cholesterol.
Too much LDL, the bad cholesterol, gets deposited in the artery walls. This attracts immune cells, causes more inflammation and damage, and contributes to plaque growth. Diet, exercise, and statins are common treatments.
Okay, so when cells are injured beyond repair, they die. Apoptosis versus necrosis. Programmed versus injury-related.
Exactly. Apoptosis is planned. Tidy cell suicide, no inflammation. The body uses it to get rid of old or unneeded cells. Necrosis is messy cell death from injury, like lack of oxygen. The cell bursts, spills its contents, triggers inflammation.
And within necrosis, we have ischemia, infarction, gangrene.
Ischemia is just reduced blood flow. Infarction is tissue death caused by that prolonged lack of blood flow. Gangrene is a later stage, often involving bacterial infection on top of the dead tissue.
And gas gangrene.
That's a particularly nasty type caused by Clostridium perfringens bacteria, which produce gas as they destroy tissue, a medical emergency.
All right, that wraps up the cellular injury part. Let's pivot to the next big section, the blueprint of inheritance and disease, starting with the basics, genes, DNA, mutations.
Okay, so genes are DNA instruction manuals for building proteins. Mutations are changes in those instructions. We should also remember RNA uses uracil instead of thymine T, and humans typically have 46 chromosomes in 23 pairs.
The blueprint mentions point mutations versus frameshift mutations. How do they differ in impact?
A point mutation is like changing one letter in the DNA code. It might change one amino acid in the protein or maybe have no effect, or sometimes stop protein production. A frameshift mutation caused by adding or deleting a DNA base shifts the whole reading frame from that point on.
So all the downstream amino acids are wrong?
Usually, yes.
Yeah.
It typically results in a completely non-functional protein, much more disruptive generally than a point mutation.
And these mutations can happen in germ cells.
Sperm and egg cells, yes. Those are hereditary, passed down to offspring.
Or somatic cells.
All other body cells.
Huh.
Somatic mutations happen during life, aren't inherited, but can still cause problems like cancer for that individual.
Okay, inheritance patterns. Heterozygous, homozygous, phenotype, carrier. Quick definitions.
Heterozygous. 2 different alleles, gene versions for a trait. Homozygous. 2 identical alleles.
Phenotype.
The observable trait or characteristic, like eye color or having a disease, it's the expression of the genotype.
And a carrier.
Someone heterozygous for a recessive trait. They have one copy of the faulty allele, but don't show the trait themselves because the normal allele is dominant. But they can pass the recessive allele on.
Got it. Now, autosomal inheritance. Dominant first.
Autosomal dominant means you only need one copy of the mutated allele to have the condition. If one parent has it, each child has a 50% chance of inheriting it.
Like Huntington's or Marfan syndrome.
Exactly. And a key feature in pedigrees, family trees, is that it usually appears in every generation. No skipping.
Okay. And autosomal recessive.
You need 2 copies of the mutated allele, one from each parent, to have the condition. Parents are often carriers.
So if both parents are carriers.
There's a 25% chance with each pregnancy the child will have the condition, 50% chance they'll be a carrier, 25% chance unaffected.
Like cystic fibrosis, sickle cell, Tay-Sachs.
Right. And these conditions do often skip generations in pedigrees.
Interpreting those pedigrees seems key. Dominant shows up every generation, recessive skips.
That's the main clue, yeah. Helps figure out the pattern.
Then there's complex or multifactorial inheritance. Not just one gene.
No, much more complex. It involves multiple genes interacting with each other and with environmental factors.
Like hypertension, diabetes, many cancers.
Exactly. Risk is harder to predict than for single gene disorders because so many factors are involved.
Okay, let's look at some specific disorders using the blueprint's 4 C's. Cause, consequences, collateral, clinical manifestations. First, Marfan syndrome, autosomal dominant.
Cause. Mutation in the FBN1 gene, which codes for fibrillin-1. Consequences. Defective fibrillin-1 leads to weak connective tissue.
Collateral effects. Where do we see problems?
Cardiovascular system, especially the aorta, can dilate or dissect. Musculoskeletal, tall, long limbs, flexible joints. Respiratory systems sometimes.
And clinical manifestations are those features: the tall, lanky build, flexible joints, maybe heart issues like valve problems or aortic enlargement. Treatment is managing symptoms, right?
Yes, monitoring the aorta, managing blood pressure, sometimes surgery, symptomatic treatment.
Next, cystic fibrosis, CF. Autosomal recessive, thick mucus.
Cause. Mutation in the CFTR gene, affecting a chloride channel protein. Consequences. Faulty channel leads to thick, sticky mucus, primarily in lungs and GI tract.
Collateral damage.
Lungs, chronic infections, inflammation, cysts, fibrosis, GI tract, blockage of pancreatic enzymes leading to digestive problems and malnutrition.
Clinical manifestations. Persistent cough, frequent lung infections, poor weight gain, greasy stools, clubbing of fingers. Diagnosis involves sweat tests, genetic tests.
Right. And treatment focuses on clearing mucus, replacing enzymes, antibiotics, bronchodilators. It's lifelong management.
Tay-Sachs again. Autosomal recessive, neurological decline.
Cause. Mutation on chromosome 15, lack of hexosaminidase A enzyme. Consequences. Buildup of gangliosides, lipids, in neurons.
Collateral effects are primarily neurological.
Yes, severe neurodegeneration. Clinical manifestations. Starts in infancy, muscle weakness, flaccidity, loss of motor skills, seizures, eventual paralysis, blindness, death, usually by early childhood.
And treatment is just supportive care.
Tragically, yes. Symptom management, physical therapy, comfort care, no cure.
Okay, shifting to chromosomal disorders. Klinefelter syndrome. Extra X in males, XXY.
Cause. That extra X chromosome, often linked to advanced maternal age but can happen randomly. Consequences. Affects multiple systems.
Collateral risks.
Increased risk of autoimmune issues, diabetes, certain heart problems like mitral valve prolapse, weaker bones.
Clinical manifestations often appear around puberty. Tall, lanky, less muscle mass, sparse hair.
Yes, infertility is common too. Treatment often involves testosterone therapy.
Turner syndrome. Single X in females, XO.
SOS. Missing one X chromosome. Consequences. Affects multiple systems again. Collateral risks include certain heart defects, especially aorta, kidney problems, hypothyroidism, diabetes.
Clinical manifestations. Short stature, webbed neck, low hairline, lack of breast development at puberty, infertility due to underdeveloped ovaries.
Treatment often involves growth hormone, estrogen therapy. Cardiac monitoring is crucial.
And Down syndrome, trisomy 21, extra chromosome 21.
Cause. That extra copy of chromosome 21, risk increases with maternal age. Consequences. Wide-ranging effects. Collateral issues are common.
Like heart defects, GI problems, respiratory infections.
Yes, congenital heart defects are very common. Also increased risk of leukemia, Alzheimer's later in life, clinical manifestations, distinct facial features, single palm crease, often heart murmur, varying degrees of cognitive delay.
Diagnosis is via genetic testing. Management focuses on the associated health issues.
Exactly. Echocardiograms for the heart, support for developmental needs, managing infections, etc.
All right, we've navigated the genetic blueprint. Now, Chapter 4 in the outline looks at how the body responds to life's demands. Stress, exercise, and immobility. Starting with stress. Eustress versus distress.
Right. Stress isn't always bad. Eustress is positive stress, excitement, motivation. Distress is negative stress, overwhelming, harmful.
And acute versus chronic.
Acute is short-term, like swerving to avoid an accident. Chronic is long-term, persistent, like ongoing job stress or financial worries. Chronic distress is one that really wears us down.
The blueprint mentions two theories. Sallee's general adaptation syndrome.
Yeah, Sallee described a three-stage response: alarm, fight or flight, resistance adapting, and exhaustion, resources depleted. A bit like a universal stress response.
Versus McEwen's allostatic overload.
McEwen focused more on the cumulative wear and tear from chronic stress. The body constantly tries to adapt, allostasis, but over time, this adaptation itself can become costly, leading to allostatic overload and potentially disease. It suggests the body might establish a new, less healthy set point.
And this overload is linked to quite a few conditions.
Yeah, the blueprint lists things like asthma, hypertension, autoimmune diseases, migraines, ulcers, skin disorders, diabetes. The idea is chronic stress dysregulates multiple systems, increasing vulnerability.
Let's zoom in on that initial alarm phase. What happens in the nervous system? It's a big cascade.
Oh yeah, sympathetic nervous system kicks in. Norepinephrine release causes increased heart rate, breathing rate, blood pressure, alertness. Blood shifts to muscles, pupils dilate, bronchioles open up, digestion and urination slow down.
And the hormonal response, hypothalamus, pituitary, adrenals.
Right. Hypothalamus releases CRF. Anterior pituitary releases ACTH. Adrenal cortex releases cortisol mobilizing glucose, suppressing immunity short term. Adrenal medulla releases epinephrine and norepinephrine, more fight or flight. Posterior pituitary releases ADH, retains water, boosts blood volume. It's a coordinated survival response.
Intense. So how do we manage this? The blueprint lists lifestyle practices, reducing caffeine, sleep.
Absolutely. Less caffeine, quality sleep, maybe even a sleep study, polysomnography if needed, phonicomnography if needed, finding balance, strong social support, humor, regular exercise, therapy if needed, all buffer stress.
And a note about exercise for diabetics, hypoglycemia risk.
Yeah, exercise improves insulin sensitivity, lowers blood sugar. So diabetics need to monitor glucose carefully and might need to adjust food or insulin to avoid lows during or after exercise.
What are the key benefits of exercise mentioned?
Reduces cardiovascular disease risk, lowers blood pressure, improves blood sugar control by increasing muscle mass and insulin sensitivity. Guideline mentioned is about 40 minutes, 3-4 times a week, but definitely consult a doctor if you have heart issues.
Okay, the flip side, immobility. It sounds like not moving has a ton of negative effects.
It really does.
Yeah.
Deconditioning of the heart and lungs. Atelectasis, collapsed air sacs in the lungs, constipation, muscle atrophy, bone loss, mental health decline, glucose intolerance.
Increased clot risk, DV2, PE.
Big time. Venous stasis from lack of movement raises the risk significantly. Also, orthostatic hypotension, getting dizzy when standing up, electrolyte imbalances from natriuresis, sodium loss, joint contractures, UTIs from urinary stasis, poor nutrient absorption, reflux, and pressure injuries.
Pressure injuries, bed sores, from stage 1 redness to deep wounds.
Exactly. Breakdown of skin and underlying tissue from prolonged pressure.
So interventions are crucial. Turning schedules.
Yes. Regular repositioning, often needing a team, passive range of motion exercises to keep joints mobile, proper body alignment, compression stockings, TED hose to help venous return, meticulous wound care if injuries develop.
And the clinical concept. It's harder to breathe lying flat.
Right. Gravity works against lung expansion and abdominal organs push on the diaphragm. Sitting upright makes breathing much easier and more efficient, especially for anyone with respiratory issues.
Okay, Chapter 5. Fueling the body, obesity, and nutritional imbalances. Starts with obesity and adipokines. Fat cells secrete hormones.
They do. Adipocytes, fat cells, secrete these signaling molecules called adipokines. They regulate metabolism, inflammation, insulin sensitivity, lipid levels, lots of things. More fat tissue means more adipokine activity.
3 key ones mentioned: adiponectin, leptin, resistin, good guys and bad guys.
Sort of. Adiponectin is generally seen as good anti-inflammatory, increases insulin sensitivity, protects blood vessels. Leptin is also usually good signal satiety, tells your brain you're full. But in obesity, leptin resistance can develop, so the signal doesn't get through effectively.
And resistin.
Generally considered bad. Linked to insulin resistance, increased glucose production by the liver, higher triglycerides, lower HDL, good cholesterol.
Got it. Then the BMI categories. Can we quickly run through those?
Sure, underweight is under 18.5. Normal is 18.5 to 24.9. Overweight is 25 to 29.9. Then obesity class 1 is 30-34.9, class 2 is 35-39.9, and class 3, sometimes called morbid or extreme obesity, is 40 and over.
But remember, BMI has limits, right? Muscle mass.
Absolutely. Doesn't distinguish between muscle and fat, so very muscular people can have a high BMI without being over fat.
Okay, bariatric surgery options.
Yeah.
Intragastric balloon.
Temporary device placed in the stomach to take up space, make you feel full sooner.
Roux-en-Y gastric bypass, RYGB.
Creates a small stomach pouch, bypasses part of the stomach and small intestine. Changes digestion and hormone signals. Not easily reversible.
Liposuction.
Primarily cosmetic fat removal. Not really a weight loss surgery for obesity itself. Can be dangerous if excessive.
Gastric banding.
An adjustable band placed around the upper stomach to restrict intake. Less common now.
Sleeve gastrectomy.
Removes a large part of the stomach, creating a smaller sleeve. Also reduces hunger hormones like ghrelin, becoming very common.
But none are magic bullets, right? Lifestyle changes are key.
Essential. Diet, exercise, behavior changes are critical for long-term success with any bariatric procedure.
And potential complications. Vitamin deficiencies.
Yes, B12, iron, calcium deficiencies are common due to altered absorption. Hernias can occur. Dumping syndromes and other risk rapid emptying of food into the small intestine, causing nausea, diarrhea, dizziness, especially after sugary foods.
Okay, briefly on eating disorders. Anorexia nervosa versus bulimia nervosa.
Anorexia. Characterized by severe food restriction, intense fear of weight gain, distorted body image, significantly low body weight, BMI often 17.5. Affects many body systems.
Bulimia.
Involves cycles of binge eating followed by purging behaviors, vomiting, laxatives, excessive exercise. Body weight might be normal or slightly overweight. Can cause dental problems, electrolyte imbalances, dehydration.
All right, Chapter 6, the language of pain. CNS role. Brain and spinal cord, afferent versus efferent neurons.
Efferent neurons are sensory that carry signals towards the CNS, like pain, touch. Efferent neurons are motor ken. They carry signals away from the CNS to muscles and glands.
Like the reflex arc hot stove.
Perfect example. Afferent signal goes to the spinal cord. Efferent signal comes right back to pull the hand away, often before the brain fully registers the pain.
Dermatomes and myotomes body maps.
Basically, yeah. Dermatome is the skin area supplied by a single spinal nerve root. Myotome is the muscle group supplied by a single spinal nerve root. Helps localize nerve issues.
Gate control theory. Pain isn't just a straight wire.
No, Melzack and Wall proposed this idea of a gate in the spinal cord that can modulate pain signals going up to the brain. Non-painful stimuli, descending signals from the brain, emotions they can all influence whether that gate is open or closed, to pain signals.
It involves transduction, transmission, modulation, perception.
Right. Transduction is converting the stimulus to a nerve signal. Transmission is sending it along nerves. Modulation is the gating process. Perception is the brain's interpretation of it as pain.
Okay, types of pain, acute versus chronic.
Acute pain is short-term, usually related to an injury, resolves as healing occurs. Chronic pain lasts longer, often 3 to 6 months or more, may persist after initial injury heals, or have no clear cause. More complex.
Neuropathic pain.
Pain from nerve damage itself, often described as burning, tingling, shooting, pins and needles, like diabetic neuropathy or shingles pain.
And phantom pain.
Pain felt in a limb or body part that's been amputated. The brain's representation of that body part seems to remain active. The neuromatrix theory tries to explain this.
Sources of pain. Cutaneous, deep somatic, visceral, referred.
Cutaneous is skin level, cut, burn. Deep somatic is muscles, joints, bones, arthritis, sprain. Visceral is internal organs, gallstones, appendicitis, often diffuse, crampy. Referred pain is felt somewhere other than the source, like heart attack pain in the arm or jaw.
Pain assessment. Oldie cart mnemonic.
Useful.
Yeah.
Onset, location, duration, characteristics, sharp, dull, etc. Aggravating factors, relieving factors, treatment tried, gets a good history.
WHO pain ladder for management. Stepwise approach.
Yes. Start with non-opioids, acetaminophen and NSAIDs for mild pain. Add weak opioids for moderate pain. Use strong opioids for severe pain. Always consider non-drug therapies and adjuvant meds like antidepressants for nerve pain at any step.
Finally, fibromyalgia. Widespread pain, tender points.
Yeah, chronic widespread musculoskeletal pain, fatigue, sleep problems, cognitive issues, fibrofog. Diagnosis often involves finding tenderness in specific points, like 11 out of 18. Much more common in women. Importantly, joints aren't inflamed or damaged.
Okay, deep breath. Chapter 7. Fluid, electrolytes, acid-base balance. Foundational pressures. Hydrostatic, osmotic, oncotic.
Hydrostatic is the pushing pressure of fluid, like blood pressure in capillaries. Osmotic is the pulling pressure of solutes across a membrane. Oncotic pressure is the osmotic pressure specifically exerted by proteins, mainly albumin, in the blood.
And albumin is key for keeping fluid in the vessels.
Absolutely. Its large size keeps it in the capillaries, creating oncotic pressure that pulls fluid back in from the tissues, counteracting hydrostatic pressure, pushing fluid out. Maintains blood volume.
Tonicity. Isotonic, hypotonic, hypertonic.
Compared to bloodstream.
Right. Isotonic has the same solute concentration, like normal saline. Hypotonic has lower concentration, water moves into cells. Hypertonic has higher concentration, water moves out of cells. Important for 5E fluids.
RAS, renin-angiotensin-aldosterone system.
Key hormone system for raising blood pressure and retaining sodium and water when the body senses low volume or pressure.
And natriuretic peptides like BMP do the opposite.
Exactly. Released when the heart is stretched, like in heart failure. They promote sodium and water excretion, causing vasodilation, lowering blood pressure. Counter-regulatory to RAAS. Fluid volume deficit and excess, just touched on briefly. Then sodium imbalances, hypo and hypernatremia. Below 135 and above 145 milliQL.
Right, low and high sodium. Cause significant neurological issues due to fluid shifts in the brain.
Potassium imbalances get more detail. Hypokalemia, first low K+, 3.5, common cause, diuretics.
Very common. Kidneys are the main route for potassium loss. Symptoms include muscle weakness, cramps, anorexia, cardiac arrhythmias.
ECG changes, PR prolonged, T flattened, U waves.
Yes, those are characteristic signs. Also increases risk of digoxin toxicity. Treatment is careful potassium replacement, never high V push. Mnemonic, low K, low energy.
Hyperkalemia, high K+, 5.2, causes like poor kidney function.
Yeah, decreased renal perfusion is a big one. Can also be caused by certain meds or excessive intake. Very dangerous for the heart.
ECG, wide QRS, peaked T waves, bradycardia.
Classic signs. Symptoms include numbness, tingling, muscle cramps progressing to weakness, diarrhea, irregular heart rhythms.
Severe level 7.0 needs urgent treatment. Insulin, dextrose.
Yes, IV insulin and dextrose help shift potassium back into cells quickly. Sodium bicarbonate might also be used. Mnemonic, high K, high risk. Cardiac arrest is a major danger.
Calcium signs mentioned briefly. Chvostek's and Trousseau's for hypocalcemia.
Right. Chvostek's is facial twitching when tapping the facial nerve. Trousseau's is carpal spasm when inflating a blood pressure cuff. Indicators of low calcium and neuromuscular irritability.
And the 4 H's leading to cardiac arrest.
Hypovolemia, hyperkalemia, hydrogen ions, acidosis, all critically disrupt cardiac function.
Okay, acid-base balance. Normal values are key. pH 7.35, 7.45, PASI 2, 3545, HCO3, 2226. The carbonic acid bicarbonate system is the main buffer.
Yes. CO2 plus H2O forms H2CO3, carbonic acid, which dissociates into H plus and HCO3 bicarbonate. It's a dynamic equilibrium. More CO2 means more H plus lower pH acidic. Less CO2 means less H plus free, higher pH, alkaline.
And lungs and kidneys compensate.
Lungs compensate quickly, minutes, by changing ventilation to blow off retained CO2. Kidneys compensate slowly, hours, days, by retaining or excreting HCO3 and H plus.
ABG interpretation. Look at pH first. Acidosis 7.35, alkalosis 7.45. Then PaCO2 for respiratory cause, HCO3 for metabolic cause.
That's the basic approach. See if the PaCO2 or HCO3 matches the pH disturbance.
Okay, the 4 disturbances. Respiratory acidosis, low pH, high CO2, caused by hypoventilation, COPD, asthma.
Right. Lungs aren't getting rid of CO2. Symptoms: confusion, lethargy, tremors, cyanosis. Treatment: improve ventilation, compensation. Kidneys retain HCO3.
Respiratory alkalosis, high pH, low CO2, caused by hyperventilation, anxiety, pain.
Blowing off too much CO2. Symptom: rapid breathing. Treatment: slow breathing down. Address cause: compensation. Kidneys excrete HCO3.
Metabolic acidosis, low pH, low HCO3, causes like DKA, renal failure, diarrhea, loss of bicarb.
Either too much acid produced or too much bicarb lost. Treatment: address underlying cause, insulin for DKA. Compensation: lungs hyperventilate.
Metabolic alkalosis, high pH, high HCO3, causes like vomiting, losing acid, excess antacids, diuretics.
Either too much bicarb gained or too much acid lost. Symptoms: slow, shallow breathing, confusion, hypokalemia, cramps. Treatment: address cause, compensation, lungs hypoventilate.
Anion gap helps differentiate causes of metabolic acidosis.
Yes. A high gap suggests addition of unmeasured acids, DKA, lactic acidosis. A normal gap suggests loss of bicarbonate, diarrhea.
And the pH potassium link. Acidosis often means high K plus Ga. Alkalosis often means low K plus A.
Generally, yes. H plus and K plus ions shift in opposite directions across cell membranes to maintain electrical balance. Correcting pH can help normalize potassium and vice versa.
Here, final block, common ailments, skin, eye, ear, chapter 41, skin disorders, inflammatory lesions, angioedema, and urticaria, hives.
Angioedema is deep swelling, potentially airway blocking emergency. Urticaria is superficial itchy welts from histamine release. Antihistamines help. Chronic urticaria, 6 weeks, might be autoimmune.
Papulous squamous dermatosis, Herald patch, pityriasis rosea, and Auspitz sign, psoriasis.
Herald patch is the initial single patch in pityriasis rosea. Auspitz sign is pinpoint bleeding when psoriasis scales are removed, indicates dilated capillaries near the surface.
Autoimmune skin disorders, scleroderma, SLE, pemphigus, SJS.
Scleroderma. Hardening of the skin can affect organs. SLE, systemic lupus, can cause butterfly rash. Pemphigus, autoimmune blistering disease. SJS, Stevens-Johnson syndrome. Severe, life-threatening reaction, often to drugs, causes widespread blistering.
Melanoma, aggressive skin cancer. ABCDE rule.
Yes. Asymmetry, irregular border, multiple colors, diameter 6 millimeter, evolving and changing. Early detection is crucial. Stage 0-4 based on spread. Treatment involves surgical removal, possibly more depending on stage.
Okay, chapter 43. Eye disorders, infections, inflammation, blepharitis, stide, chalazion, conjunctivitis.
Blepharitis, eyelid inflammation, blocked oil gland cystitis, conjunctivitis, conjunctiva pink eye. Inflammation of the conjunctiva can be infectious or allergic.
Structural issues, corneal abrasion, entropion, ectropion, pingueculum pterygium, exophthalmos, and ophthalmos.
Corneal abrasion, scratch on cornea. Entropion, ectropion, eyelid turning in out. Pingueculum pterygium, benign conjunctival growths. Exophthalmos, bulging eyes. Thyroid disease often, and ophthalmos, sunken eyes.
Epiedema, swelling of optic nerve due to high ICP.
Yes, a serious sign needing urgent investigation. Indicates high pressure inside the skull. Causes headache, vision changes, optic disc looks swollen on exam.
Cataracts, clouding of the lens.
Very common with age. Causes blurry vision, glare. Risk factors: age, smoking, diabetes, UV exposure. Treatment is surgery to replace the cloudy lens with an artificial one.
Last chapter, 44, ear disorders, hearing loss, conductive versus sensor neural.
Inductive, problem in outer or middle ear blocking sound transmission. Wax, fluid, bone issues. Sensor neural, problem in inner ear, hair cells, auditory nerve or brain pathways, noise damage, aging, genetics.
Otitis media, middle ear infection.
Yes, inflammation infection behind the eardrum. Very common in kids, often after a respiratory infection. Causes earache, fever.
Benir disease, inner ear fluid problem.
Thought to be. Causes episodic vertigo, spinning, fluctuating hearing loss, tinnitus, ringing, roaring. Treatment involves managing symptoms, low-salt diet, diuretics sometimes.
Wow, we covered an incredible amount of ground there, tracing all those connections.
It really does show how interconnected everything is, doesn't it? Seeing how a cellular process like the sodium pump relates to heart rhythms, or how inflammation underlies so many different conditions.
Absolutely. Those aha moments, like seeing the RAAS and BMP as opposing forces managing fluid balance or understanding the link between pH and potassium. It makes the complexity a bit more manageable.
And hopefully, for you listening, it sparks some thought about how these fundamental processes are working inside you right now. Maybe thinking about lifestyle choices or even family history in the context of things like multifactorial diseases or genetic predispositions.
It's a powerful reminder of the body's constant striving for balance, for homeostasis against all kinds of challenges, and how disruptions, even small ones, can ripple outwards. It leaves you with a real appreciation for the complexity, but also the resilience of human physiology.